All right, good evening, everyone. This is chapter 15 of the Psychology Second Edition textbook. And so tonight we're going to be talking about psychological disorders. There's a lot to talk about in this chapter. We may not have a chance to go in depth with a lot of them. I will probably spend a little bit of time around schizophrenia. We're going to have a video. But first, before we get started, what I'd like to do is just kind of remind everyone what we talked about in the beginning of the semester, right? You know, that words kind of matter. And so in today's lectures and discussions, we're going to be, talking about some sensitive issues. And one thing that I like to point out is that you never know who you're attending class with, right? So some of your peers may have like personal lived experience, right? With substance use disorders, for example, with co-occurring disorders, with depression, anxiety, even possibly schizophrenia, or they have experience with their loved ones experiencing these things. So we want to make sure that we're sensitive to that and that we're respectful, right? So I just kind of want to put that out there. Very, very, very rarely have I ever had an issue in any of my classes. I still kind of put this out there though, because if the other thing is if something unfounded or non-scientific is expressed, I will probably like intervene at that point and go, well, that's not backed up by science. That may be anecdotal. But not really appropriate for the conversation. And if that happens, please realize that I'm just using this as a learning experience, and that it's not a criticism for anyone. All right. So here's what I'd like to do first, just to kind of get everybody's feet wet on the topics we're going to talk about tonight. So I have a series of 7 questions here. And so what I'd like you to do is maybe take a screenshot of it, since the screen share in the breakout rooms doesn't always work or hasn't been working. As a group, when you guys get together, I'd like you to answer these questions, either true or false questions, right? And I'd like you just to go through and answer the questions. And then we're going to come back as a group and see what you guys came up with, and we'll review the questions together. So I'm going to assign breakout rooms, and we'll do the same thing. Somebody can be the spokesperson for the breakout room when we come back for our discussion.
You're mute, Professor.
All right, so we had a little internet glitch and lost my connection, so we're back. So as I was saying, I'm going to break everyone up into breakout rooms, and like we have done in the past, just have a spokesperson, and you guys talk together as a group, answer the questions, and then we're going to come back together. So I'm going to pause the recording now and assign the breakout rooms. Take your screenshots and we'll get going. All right, so you guys did a great job. Most everybody was, all the groups were saying that a majority of these were false. And so here's what I'd like to do. I'm going to go ahead and give you the answers, and then I'm going to kind of talk about this here for a few minutes. So the answers to all of them are false, right? So abnormal behaviors are not always bizarre. And the other thing about abnormal behavior is it's not always, doesn't always need to be pathologized. And when I say pathologized, a pathology is, where someone is being rendered a diagnosis, where it's interfering with their life functioning. And I'll give you an example. You guys know I've been working in the substance use and mental health field for a long time. And, you know, sometimes we have some clients, I'm thinking of a client from the past right now that he just had a very different way of dressing. And I can remember one of the other counselors coming to me one day and saying, don't you think that's odd? And shouldn't we do something about it? And, you know, my answer to that was no, because it wasn't really interfering with his work, love, or play. And work, love, or play, those are the things that I look at in a person's life to determine if, you know, if something is crossing the line of being a significant impairment, right? Just because something is odd to us does not necessarily make it pathological, right? So, and then here's the other thing, and it kind of ties into what I was talking about too. A clear distinction can be drawn between the normal and abnormal. That is not really true either. You know, there are different, and we're going to talk about like culture and things like that in the, later on in the lecture. But again, when we're looking at behavior, you know, we kind of have to take the whole person and their life experience into account, right? Now, number 3, and by the way, these come from what are known as myths, mental health myths. And number 3 is one that some people actually worry about, right? That if a person has been hospitalized, or if they have schizophrenia, or, you know, some kind of delusional disorder, or they've been, like I said, psychiatrically hospitalized in the past, that they are unpredictable and dangerous. And the studies don't really bear that out. They're more likely to be more dangerous to themselves than they are to others. What's unfortunate, though, however, is that in the rare instances where this does happen, that's what gets all the news. And it kind of creates the idea that all psychiatrically, or as a group, a majority of them would be dangerous and unpredictable. And that is generally not true. And that is why this is false. And then number 4, mental disorders indicate a fundamental deficiency in personality and are thus shameful. You know, that's not true either. We're going to be talking about, you know, biological basis, genetic basis for mental disorders, and so it really isn't about, you know, a person's morality, their personality, and it should not be shamed. As a matter of fact, here we're also going to talk about stigma too. You know, some people do not get help because of stigma, worried about being judged, and then they suffer longer as a result of that. Let's see, number 5, since mental health, sorry, misread that. Since mental illness is so common, there is a reason to be fearful of one's own vulnerability. And that is false too. And we'll touch on that again a little bit later on when we talk about, like, for instance, the diathesis stress model, when we talk about heritability, and of course, the statement in and of itself, again, this comes from a myth, right? Is not really well written, right? So what does it mean? What does the myth mean that it's so common? You know, for instance, in the general population at large, schizophrenia is less than 3% of the population at large. So that is not common. As a matter of fact, that's rare when you think about it in the grand scheme of things. And then number 6, geniuses are particularly prone to emotional disorders. Again, that it comes from another myth that, you know, that if you're highly intelligent, that you have other emotional or mood issues going on, and that is not true. And then number 7, recovery from most mental disorders is impossible, and that is false. Actually, a lot of mental health disorders, are treatable. Some individuals, I'll give you an example. For example, PTSD. Person can be diagnosed with post-traumatic stress, meet all the criteria for it, go through treatment, and then later on being reassessed, they no longer meet the criteria. So once you no longer meet the criteria, you no longer have the diagnosis. So that's an example. The other thing, I stepped into one of the groups, and right when I came in, and I loved the conversation because you guys were talking about symptom management. A person can be in recovery and managing their symptoms and being able to attend to their activities of daily living. And for some clients, that's as simple as getting up, take a shower, brushing their teeth, making their bed, doing their chores, right? Where before they were not able to do those things. And, when I talk about ADLs, activities of daily living, usually that's on the one side of the spectrum of, the severely and persistently mentally ill, those individuals that experience those symptoms. And then of course, it's on a continuum, there's a wide range, right? But recovery is not impossible. Some of it is all about symptom management, and it's something that they'll have to do for the rest of their life. Others will meet criteria at some point in their life for one of the DSM-5 diagnosable disorders, and then they may no longer meet the criteria. For example, here's another one. So a person with a substance use disorder, severe, right? After a year, they're in sustained remission. And then at some point, they're really no longer meeting criteria for a substance use disorder. So that person would be in recovery. They're attending to their life, and all is well. So anyway, I hope this was a helpful exercise. I kind of like to do this to throw some myths out there and see where people are. And you guys did a great job. So kudos to the symptom management group. That was pretty awesome. I love that. All right, so let's talk about what is the definition of a psychological disorder. It's kind of where we're going to go and talk about these various definitions. Hold on, having a little, there we go. So earlier you heard me use the term pathology, right? And so when we're talking about psychopathology, that's the study of psychological disorders. That includes their symptoms, what causes them, how they can be treated, what are the evidence-based practices that can be used to assist an individual experiencing those symptoms to enter recovery or have symptom management and be able to attend to their life. And then a psychological disorder is a condition that's characterized by abnormal thoughts, feelings, and behaviors. And abnormal thoughts would be like kind of like delusional thinking as one idea of that. For instance, trying to think of a good example. And my brain just went blank. Oh, here's an example: 5G towers. I worked with a client recently that really has this idea that he's being tracked by 5G towers, right? And that's, that would be kind of some abnormal thinking, right? And so that affects how he feels, and it also affects some of his behaviors. That would be an example. Excuse me. And then something I want to point out, it's kind of here just above the pictures, right? And I kind of made reference to this before. Just because something is atypical, in other words, out of the norm, does not mean that it's disordered, right? So the client that I referred to, from a few years back that had atypical dress, he would, yeah. And one of the counselors was like, shouldn't we address that? And I'm like, no, no, I don't think we should, because that in and of itself, we would not pathologize that, right? So if you think of, so here's an example, people with red hair. There's actually not a whole lot of people in the world with red hair, but it's not abnormal, right? It's unusual, it's atypical, but it's not abnormal. So using that as kind of as an example. So then moving on, right? So I kind of briefly mentioned cultural expectations earlier. So, violating cultural expectations in and of itself is also not enough to identify a psychological disorder. And so, in other words, we don't rely on one simple thing, right? Oh, that's unusual, so that's pathological, and therefore the person needs to be treated, because that is not necessarily true. All right. Let's see. So social norms can vary between cultures. This is what I was saying earlier in that earlier slide when we were talking about the myths, right? We have to consider what is appropriate in one culture may be viewed differently in another, and especially here in the United States. So we have, we're definitely a multicultural nation. We have, lots of cultures represented here. And I'll give you an example too. If you've ever heard of cupping, and cupping is normally I show this in my AODS class, but cupping, if a person that's engaging in cupping, it will leave welts and marks on the person's body. And to an untrained individual, or maybe just seeing part of the person, if they might think that the individual is experiencing some kind of abuse, when really they're practicing something from their culture. And mistakes can be made in that way. We have to, be mindful of cultural implications, what the people are doing in their own homes, and what is the cultural expectation there. Remember, sometimes we come from an ethnocentric kind of perspective. Being in the United States, majority white, majority Christian, things can be misinterpreted if, they see something that's not within what they consider the norm. I hope that makes sense. Let's see, we got a chat. So either there's a question, a comment, or I didn't make sense. Oh, it's like the chest scraping for increased lung health. Okay, yeah, that would be a very good example. And I'm assuming that would leave some kind of marks. And yes, it could be mistaken for abuse. Cupping can be mistaken for abuse. Yeah, absolutely. Good examples. And then the other thing looking at is according to Wakefield, he defined psychological disorders as including what's known as harmful dysfunction, right? And so dysfunction occurs when an internal mechanism, either the person's thinking, right, their cognition, their learning, how they're perceiving the world, when that breaks down and they're not able to function normally within that. And it's also that it has to be harmful in order for it to be classified as a disorder. right? So in other words, it leads to negative consequences for the individuals or others around them, right? And then of course, this is as judged by the individual standards, by the standards of the individual's culture as well. So that has to be taken into account. So earlier I used the 3 words, work, love, and play. So work, is it affecting the person's career, their ability to make money, their ability to function, contribute to society in that way? Is it affecting their love life, right? Are they able to maintain those close, intimate relationships, right? And by the way, love can also include non-sexual family, friends, things like that. And then play. Does it interfere with their recreational activities? Did they once, engage in certain activities that now they've kind of withdrawn from, right? So these are some ideas to think about when we're looking at a person's situation. And then the American Psychological Association, the APA, their definition of the psychological order is that it includes significant disturbances in a person's thoughts, in their feelings, and in their behaviors, and that it's outside cultural norms. And that also these disturbances reflect some kind of biological, psychological, or developmental dysfunction. So it has to be impairing them in some way. And that these lead to significant distress or disability in one's life. So all of those characteristics kind of have to be at play. So a person can have some unusual thoughts and feelings, but they're still able to go to work. It's not causing them significant distress. For example, I'm going to go back to the 5G telephone tower guy. He's working. He's, doing the things he needs to be doing. It's not really impacting him. Now, he does want to work on that, and that's awesome. But at this point, it's not really causing him all that significant distress, right? So we just have to be careful when rendering diagnoses. And the other thing, going back to that one myth that recovery is impossible. People do recover and they no longer meet criteria for psychological disorder. So then, they don't, I've been doing this for a long time, and I've seen clients come in and they will come in with a list of diagnoses.
Go get my charger.
And then go on mute.
It's about to die.
Hold on one second.
She muted already.
Oh, okay, good. Sorry, I was trying to find her real quick. When I'm sharing the screen, it's hard for me to see, and I didn't know who it was. This little oopsies happen when we're recording live. That's all good. So the other thing to point out here too is, going back to where I was, I've had clients come in and they will have, 4 or 5 diagnoses that they've received over the years. And, they go to a different place and they get a new diagnosis. And, what's unfortunate for some of them is they carry this around. And even if they no longer meet the criteria for that, so sometimes I try to help and work with clients in that way too, to actually understand where they really are and help them understand where they really are. One thing I always say is that you are not your diagnosis, right? A person is experiencing symptoms of depression. They are not depressed, or they're not their depression. They are not their anxiety. They experience symptoms of anxiety, and then we try to work on those symptoms to ameliorate that. And there are different ways to do that. And we'll talk about treatment in the next chapter on Wednesday. So the Diagnostic and Statistical Manual of Mental Disorders, 5th edition, is currently what we are using now to diagnose individuals. And so it's published by the American Psychiatric Association, and the most recent publication was in 2013. So that's the most recent edition. It's kind of a thick book. I'm actually gonna, hold on one second. So I'm gonna pause the recording here for a minute so I can stop sharing the screen, because I brought my DSM with me, and I'm just gonna kind of show you, but I don't want to show everybody's picture on YouTube. So that's why I'm gonna pause and do this. Yeah, so the DSM, the DSM-5 is what we're using. And as I was just describing to you, so it categorizes and describes each disorder that's in there. It gives the diagnostic features. So in other words, it does an overview of the diagnosis. It gives the diagnostic criteria, and the example that I used just a minute ago while we were not recording was on alcohol use disorder, right? Which has 11 diagnostic criteria. And then depending on how many criteria are actually met for an alcohol use disorder, you know, they would be classified as either mild, moderate, or severe. It also talks about the prevalence for the disorder in question. In other words, how much of the population is thought to be afflicted. So for example, a few slides back, I talked about schizophrenia. The general population at large, I believe it's 3%. Where, and we'll talk about heritability, whereas if you have a twin that has schizophrenia, you're at like 45% chance of getting it, which is way above what the general population is at large. So it talks about prevalence and risk factors, and it also provides information on comorbidity, which is a term that I'm going to want you to know as well. Comorbidity basically means that there's two things happening at the same time, or co-occurrence. The old term, for those that may have been around for a little while, was dual diagnosis. And usually that meant that someone had a substance use disorder and some other mental health concern like depression, anxiety, PTSD, etc. So whenever you hear comorbid, comorbidity, co-occurrence, we're really talking about the same thing. But the term that I want you to use first is comorbidity. That's what I want you to take away from this lecture. And then, so here's a Venn diagram, for example, with comorbidity, right? So the green circle, you have OCD, right? Obsessive compulsive disorder. And then the blue circle, you have major depressive disorder. And then where they overlap, that's where people are experiencing both of those conditions, which is about 41%, as you can see from this Venn diagram. So this is a very frequent occurrence. Substance use disorder and major depressive disorder, there's comorbidity there. Anxiety disorders, also OCD and SUDs, there's comorbidity there. So an individual can be experiencing more than one mental health concern at a time. And when working with those, by the way, we would be treating both of those concurrently, right? And then the ICD-10 is the current international classification of diseases. So for example, in my line of work, when I'm rendering diagnoses, And I'm required by the County of San Diego to use the DSM-5 description. So in other words, alcohol use disorder severe in early remission. If the person has 3 months of abstinence, between 3 and 12 months of abstinence, they're in early remission. And then I have to use the ICD10 code, which is F11.21. And really, we're using those as descriptors, and it's also used for billing and classifying disorders. So it's just a classification system. So if you go out into the working world, if you work at a mental health clinic or at a community clinic or a substance use disorder treatment program, whether it be inpatient or outpatient, you're going to be seeing ICD-10 codes and DSM-5 descriptors for whatever diagnosis has been rendered for a particular individual. I cannot remember if, let me see, before we move on, I don't think I have a slide on this, and it's really not going to be on the test, but since we're talking about diagnoses and we're talking about stigma, and before we go on break, I kind of want to talk about this for a minute. You know, I shared that I worked with veterans at an inpatient substance use disorder treatment program for veterans, and many of them, you know, have substance use disorder and a co-occurring disorder of PTSD, depression, anxiety, etc. You know, we're required to render a diagnosis, but those individuals, and some people do not believe in diagnoses. There are actually therapists and clinicians out there that don't do diagnosis. And if you're working independently and you're not, you know, billing insurance or whatever, you could probably get away with that. And I see the downside of diagnosis too, as it's a label. It can be stigmatizing. For instance, working with the veterans, they understand if they have PT, and I'm speaking in general. This isn't for all of them. But I've talked with enough of them where they don't really like the term disorder. So whenever I'm speaking to them about what we're working on and their experiences and symptom management and all of that stuff, if I refer to the situation at all, it's usually post-traumatic stress without the word disorder. But if I'm writing it down, I have to use the descriptor as indicated in the DSM-5. And the reason why I bring that up again is just because some of you may be like, oh, I don't like labels. And I totally get that. The upside of diagnosis and why diagnosis is important is if you have an accurate diagnosis, then you know what you're working on. And if you have an accurate diagnosis and you know what you're working on, then you know the evidence-based treatments that work well for that. And so on that side, diagnosis is very is important. How a clinician handles that, like I said, like I would usually drop the word disorder. Even when I'm talking with my substance use disorder clients or clients that are experiencing substance use disorder symptoms, right? I just refer to it as substance use. You know, and drop the word disorder, just because that's very stigmatizing. All right, let's see. Okay, I'm just managing the time here. So let's talk about a little bit of history. You know, way back in the day, you know, before science was really taking over, you know, people that, for instance, a person that was experiencing schizophrenia back then, hearing voices, seeing things, auditory hallucinations, visual hallucinations, tactile, in other words, touch, hallucinations, were believed to be possessed, right? or that there was some kind of black magic or witchcraft involved, or they were needed to be tortured or beaten or have an exorcism in order to remove the spirits. You know, in the next chapter, we're going to talk about trepanation, which is drilling holes in the head to release the spirits. But that was the best information that they had. They didn't know. So schizophrenia isn't nothing new. It's probably been part of the human condition for as long as we've been around. And I'm using that as an example. But people didn't know what it was. You know, another interesting thing from the 11th to the 17th centuries was this thing known as dancing mania, where people would just dance for weeks or on end, and screaming of having terrible visions and things like that. Don't know what the cause is, but at the time it was attributed to many, you know, to supernatural forces, evil spirits was causing this. I'm not sure when the last dancing mania was recorded, but it's interesting. Don't know what it's caused, and you know, it's came on suddenly and it's not really around anymore. So, you know, who knows what that was? But, you know, evil spirits, that's what it was attributed to. And this slide talks about heritability estimates and the biological perspectives for people who are experiencing symptoms of psychological disorders, right? So we know that there are genetic factors. We know that there are. And as we go through tonight, we'll see some examples of like depression has, they've identified a gene that regulates serotonin production, right? And so if that gene is affected, then serotonin production is going to be affected, and making the person at risk or vulnerable to experiencing, you know, those brain abnormalities or chemical imbalances, right? So there is biological evidence to support this. In this slide, and I kind of talked about it earlier, I'm going to use my laser pointer here. So as you can see, the general population at large, you know, very, very small percentage of estimates for individuals having schizophrenia in the population at large. Now, as there's relations, as there's shared genes, you see that it begins to kind of jump up. So first cousins, about 12.5%. So it jumps up from about 3 to 4% estimate here. It's almost 3 times that, right? To 12.5%. Same thing with aunts and uncles. It looks like it's about the same there. Even though it says 25%. Oh, sorry, I misread it. 12% of genes are shared, and it's about looks like it's about 4 to 5% there. So you see, as the closer the number of genes that are shared, the higher the prevalence or the higher the risk. And then twins have the highest risk. They share 100% of the genes, and they're just shy, looks like about 48%, just below 50% chance or risk of developing schizophrenia. And there's also some interesting studies that presentation I went to in 2016 in Denver that talked about some new research on schizophrenia, that, you know, over pruning when the brain is maturing during late adolescence and early adulthood, that over pruning may contribute to that. Still research to be done on that at that point. So again, indicative of a biological situation. In other words, beyond the person's control. There's just no way they can control that. And then the diathesis stress model is something else like that I wanted to talk about. So you have two people, right? They share genes. Let's say the identical twins. Let's use that as an example. Identical twins share 100% of the genes. They have about a 48% chance. One has it, the other person has about a 48% chance of also developing schizophrenia. Why does one develop it and one not? Right? Why does that happen? So diathesis is basically, what that means is it's a predisposition. There's a vulnerability that an individual is at risk for this, right? Maybe in their genetic makeup. And if you recall the range of reaction from earlier chapters, just because an individual may have the gene or the gene dysfunction, depending on what the situation is, does not necessarily mean that they will go on to develop the disorder. The diathesis stress model says that there's a biological component, right? That there's a predisposition that this person may be vulnerable. And then there's something in the environment, a stressful childhood, some kind of, stressor, something happens that now makes that individual more at risk for development of a disorder. And so this is another thing that I kind of want you to take away from this lecture, the diathesis stress model, right? So linking stress or adverse environmental situations and events with a predisposition makes the person higher risk for developing a disorder. Another example of this is, let's say we have two parents, and one of the parents suffers severe depression and has lifelong, right? They've had depression. They have children. We know that depression is heritable, that there is a genetic component to it. So the children are at risk for depression. Does not necessarily mean that they will develop depression. They could. There's a predisposition to it. But it might have to do with their environmental situation, right? And that's kind of going back, if you remember, range of reaction from the biopsychology chapter. And we also talked about it, oh shoot, we talked about it in another chapter too. I can't remember which one. All right. Oh, I did forget to point out that the diathesis can also be a psychological vulnerability. Usually I'm thinking more biological, but it can also be psychological. All right, so let's do this because we're going to move into the next section. Let's go ahead and take a break. It is
7:11.
Yeah. So let's come back at 7:30. Let's make it 7:35 p.m. just to make it easy. Round it up by a couple of minutes. All right, we're coming back from break. And we're going to move into anxiety disorders. And some of you may find this interesting. Actually, I have a long list of phobias you'll see in just a few minutes. Make sure, hold on, everybody, make sure you're please muted. Please mute yourselves.
Saying he's going to ask if he can drink.
All right, so in the interest of time, I normally show this video, but it is available in Canvas. And if we do have time, I might come back to it at the end. But there is a longer video that I want to show, and I want to make sure that I have time to show it. And I think you guys will like the video, and we'll have a discussion about the video. It's on schizophrenia and Eleanor Logden. It's just a good video that I like to share. So I'm going to talk about fear versus anxiety and anxiety disorders in general. So when it comes to fear, that's our instant, imminent threat reaction, right? If you recall from the stress chapter, right? If our primary appraisal is that this is a threat, it's activating our fight or flight response, our sympathetic nervous system. Anxiety is apprehension or avoidance. It's nervousness, cautiousness of a potential threat, danger, or negative content. But with anxiety, it's more like fear is instantaneous. It can come, it can go. Anxiety tends to be a little bit longer in duration, if that makes sense. The thing about fear, and actually both of these, is that it motivates people to take certain actions, right? To avoid things. Sometimes known as, well, in other areas like safety behaviors. These are things that people will do in order to kind of ameliorate the anxiety. And with anxiety disorders, it's estimated that approximately 25 to 30% of the US population will experience it during their lifetime. We'll have an episode of this during their lifetime. It's more common in women than men. And most frequently occurring class of mental health concerns, right? So anxiety gets reported a lot. And, it's the fear versus anxiety, whereas that can motivate people to change things, avoid things, maybe even make some changes in their life, right? We've all heard the term like healthy fear. And we all experience some kind of anxiety at some point, right? Like, I bet you if I had you guys do a project, well, like I do with my AODS students, they have to do a project where they present treatment center stuff to the class, right? To build what's known as a resource notebook, but they have to make a presentation. Now that can be anxiety provoking, right? So the experience of fear and anxiety is normal, right? But when it becomes excessive, persistent, long in duration, right? And causes disturbances in our behavior, that's when it begins to cross the line of, remember, where it's affecting our work, love, and play, right? That's where it may be now approaching something more severe that's actually diagnostic, etc. Let's see. All right. And then, of course, we've want to talk about phobias. And when it comes to specific phobias, that's, again, excessive, distressing, persistent fear or anxiety about a specific object or a situation. So if you remember Watson and the little Albert experiment, right? He kind of induced an anxiety or fear response with little Albert and little white furry things, if you'll recall. So that would be an example of a phobia. So some common phobias, I think everybody's heard, maybe agoraphobia, aerophobia, fear of flying, arachnophobia. There was even a movie, claustrophobia, right? These are some common ones that you hear about. And of course, going back to the agoraphobia, that's actually listed as a separate anxiety disorder, but that's intense fear of, avoidance of situations in which it's difficult for a person to get away. They might experience a panic attack. And this is like in large crowds, public transportation, being outside the home, like they might not leave their home for months, years on end on severe cases, right? They just can't go outside. The prevalence for this is about 12.5% of the US population at some point in their lifetime. Oh, and there's a chat. Let's see what it is. Okay. So it's connectivity issues. That's why I record these, so you can catch the parts that you miss. All right. So here's a partial list of phobias, and I am not going to read through all of these. I'll leave it up on the screen for a second. You can kind of see some of them. I like the dentophobia. Yeah, so fear of dentists, right? Barophobia, fear of gravity. Yeah, so gatophobia, fear of cats. Yeah, just some, there's a whole lot right here. And yeah, and somebody typed in the chat, now with the pandemic, my neighbor has a phobia about going to the market. So could be a phobia, or it may just be a temporary fear situation right now. And again, this is one of those things, and I see where you're going with it, but we don't want to list it as a phobia when it could be just a circumstantial, situational fear at the moment that will go away once the pandemic kind of alleviates, once we finally get through this fourth wave that we're having, right? But yeah, so let's see. And that's a good example of what I was talking about. We don't want to pathologize everything. Oh, by the way, please don't, after this and after reading the book and doing the homework and your research papers, don't go diagnose your family or friends. That's a little joke I often tell. Here's another page. I just switched the page and the list goes on. So you can see that that there are a lot of phobias that can be identified. All right, so if you recall from the learning chapter, chapter 6, and when we talked about that, Dr. Pavlov and classical conditioning, one of the things that lost my train of thought. Hate it when my Wernicke's area, my Broca's area don't want to cooperate. But phobias are thought to be learned situations, right? So for instance, classical conditioning. If you recall the unconditioned stimulus here, so I'm just gonna go through this example right here of a child being bitten by a dog. So the unconditioned stimulus is the actual situation where the child is bitten. Then dogs become associated with biting. So just seeing the dog, now the dog is now a conditioned stimulus, and the child will experience fear around dogs, which is the conditioned response. So I often will, this happens with triggers with substance use disorders and other things, right? So whenever we're talking about classical conditioning, we're talking about learned. This is something we have learned. And anything that can be learned can be unlearned, and that's the good news. Then there's vicarious learning, where the child observes a cousin or another relative react with fear around spiders. So see the spider, the relative, somebody else reacts, and through vicarious learning, the child learns to express that same fear, even though spiders have never presented any problem for him. Does that make sense? So I'm observing the model's reacting in fear. I learn, oh, maybe that's how I'm supposed to be reacting, and that's what happens. And then lastly is the verbal transmission of information. So the child is continuously told that snakes are dangerous, snakes are dangerous, snakes are dangerous. And then the child begins to fear snakes, right? So classical conditioning, vicarious learning, and verbal transmission of information. So here's a question. Why are certain phobias more common than others? And so the answer to that is there's a theory that argues that because our ancestors associated certain stimuli with danger, for example, spiders, snakes, heights, that we are actually evolutionarily predisposed to associate these stimuli with fear. So that would be an evolutionary theory behind that. And then there's social anxiety disorder. And that's characterized by extreme fear and avoidance of social situations in which the person could be potentially elevated negatively or judged negatively by others. And the issue here is in order to avoid that, they actually withdraw, right? And so, and in the withdrawing, now there's serious impairments in their life, right? Remember, work, love, and play, right? So they may have issues at work. They may withdraw from recreational activities. They may stop dating, or they may, I'll give you an example. So sometimes in the past, I've had clients that have experienced social anxiety disorder. And, since most of my work is with individuals that experience substance use disorders and they're engaged in treatment for that, a lot of things that we do is recommend, go to an AA meeting, go to an NA meeting, get a sponsor, build your sober support network. Well, an individual who has social anxiety is going to really struggle with doing that, right? Because their tendency is to withdraw. They engage in safety behaviors. I kind of mentioned safety behaviors before. This is some more examples of it. They look down. They don't make eye contact. They get really nervous if they get, for instance, if they're in an AA meeting. I had one individual tell me one time, he said, I always get really nervous and I lose track of what I'm doing in the meeting, and I'm not paying attention because I'm thinking about what I'm going to share about, and I'm rehearsing my lines. And then they call on me and I still freeze up. So so it causes them to withdraw. And in that withdrawal, other people react to that. If you recall in the last chapter where we were talking about that hostile, angry interaction. So the one person believes that people are no good, basically, and based on that belief, they mistreat people, and then the mistreated people react to the mistreatment, which subsequently reinforces that belief, and it's just a vicious cycle. And it's the same thing here with social anxiety disorder, right? So they engage in these safety behaviors. They're unapproachable, so they don't get approached, and it reinforces their beliefs sometimes that, I'm being judged. They don't like me. I'm being evaluated negatively, and so it kind of reinforces that. And what's interesting with this, and I was kind of talking about it with the clients that I work with, is that there is a high rate of comorbidity with, specifically here it says alcohol use disorder. Now I haven't done any research beyond that, but I can tell you anecdotally that I'm finding it with opioid use disorder, with amphetamine type substance use disorder. I'm finding it across the board with substance use disorders in general. But alcohol use disorder has been studied, and there is that high rate of comorbidity. And part of this is self-medication. The individuals that I work with, when they talk about their alcohol use, they describe it as like a social lubricant. I drink and the anxiety goes away and I can talk to people. If I don't have the beer, then I can't do it. Some risk factors regarding this. Again, we're talking about conditioning here, right? So fears of social situations that develop through conditioning. In other words, they've learned it, right? So 92% of a sample of adults with social anxiety disorder reported a history of severe teasing in childhood. So they were teased in childhood. That's how they were conditioned. So when I'm out and about in social situations, I'm vulnerable. And as a result, it brings on that anxiety. And then there's the behavioral inhibition, right? And that's the consistent tendency to show fear and restraint when presented with unfamiliar people or situations. And if you've ever met someone that is like avoiding eye contact or seems nervous around other people, it may be an indicator that that individual may be experiencing some social anxiety. But again, don't go diagnosing people. I just got a warning that my internet is unstable, so hopefully you are still hearing me well. All right, panic disorder. Now this is an extreme fear and discomfort that develops abruptly. And it reaches a peak within 10 minutes, and it is an over activation of the sympathetic nervous system. And a person is going to experience, like, they get dizzy, lightheaded. They could feel their heart races. They get nausea. Panic attacks are extremely disturbing to individuals that experience it. And there's comorbidity here as well. Person with an anxiety disorder can also have meet the criteria for panic disorder. They can also meet major depressive disorder, and panic disorder also has comorbidity. So but think about this, it's like very extreme. Let's see. So some of the genetic heritability, it's estimated at about 43% that of heritability. And then the locus coeruleus in the brain stem is possibly involved. That's an area that has been identified, and because that is an area that has the norepinephrine, that's a major source of it. And remember, norepinephrine is one of the neurotransmitters that triggers fight or flight response. And the activation of it, of course, is associated with the anxiety or fear, and it produces this panic-like symptoms in non-human primates as well. So, and again here, conditioning theories. So classical conditioning, we're coming back to that. That it's learned, that it's conditioning to subtle body sensations that resemble those normally occurring when one is anxious or frightened. So your hands shake, things like that. You start to feel, or a person starts to feel that way, they've been classically conditioned, and it goes off the chart. And then also there's cognitive theories, right? That individuals with the panic disorder are prone to interpret ordinary body sensations catastrophically, right? So it's kind of like catastrophizing what they're experiencing. And then by doing that, again, I always say your mind is a powerful, powerful organ, right? That sets the stage for the panic attacks. So in some patients, reducing those cognitions has proven to be effective. So that would be an example of maybe using like cognitive therapy with an individual on that. And we'll probably see that in the next chapter. We will actually talk about cognitive therapy, cognitive behavioral therapy, etc. And then there's generalized anxiety disorder. And that's a relatively continuous state of excessive, uncontrollable, pointless worry and apprehension. And some of the criteria here, now remember, this is continuous. It's not part of another disorder. That's the other thing, it has to be ruled out. And the symptoms occur more days than not for at least 6 months. So earlier when I was talking about diagnosing individuals, sometimes we kind of have to, watch and see and monitor before you can actually render an accurate diagnosis. Somebody comes in my door, I see them for 15 minutes and I'm giving them a diagnosis that may not be accurate. Fortunately, I'm in a position where the clients that I'm working with, I get to see them for extended periods of time, and it can be more accurate. But the reason why that's important is, again, for at least 6 months. Now that can be self-report, the client can be telling you that. But I still like to also monitor the clients as well. So symptoms are accompanied by any 3 of the following, right? And so if, remember earlier I showed you the DSM-5 and the list of criteria. So this would be listed out in the criteria: restlessness, difficulty concentrating, easily fatigued, experiencing muscle tension, irritability, and sleep disturbance of some kind, right? All they need is 3 of those, plus more days than not, for at least 6 months to meet the criteria for this diagnosis. And this affects about 5.7% of the population. And women are 2 times as likely as men to experience the disorder. And then, of course, comorbidity, again, we're talking about with mood disorders and other anxiety disorders. Some causes, again, cognitive theories. Worries represents the mental strategy. So this is how we're thinking to avoid more powerful negative emotions that may be stemming from earlier unpleasant or traumatic experiences. So trauma history certainly could be involved here. And the actual thinking about it, the actual worrying itself acts as a distraction from remembering the childhood experiences. So I'm worried about all of this over here today, so that it kind of distracts me from other memories that are worse to think about. And a longitudinal study found that childhood maltreatment was strongly related to the development of the disorder during adulthood. So early childhood experiences, mistreatment, strongly correlated to this. All right. So now we're moving into obsessive compulsive disorders. So OCD is one of those disorders that involves intrusive and unwanted obsessions. And so that's something that you kind of have to think about, that the individual is experiencing this and they don't want to. Oftentimes they will know that it is, that other people don't experience this, right? That it is atypical, which can also make it worse for them too, right? So it becomes intrusive, it's unwanted, they're obsessed. And then what it results in, oftentimes, is the need to engage in repetitive behaviors or mental acts. For instance, I worked with a client one time that his mental act was to count to 4, 1, 2, 3, 4, 1, 2, 3, 4, 1, 2, 3, 4. That's what he would do. And it was like a repetitive mental act that he would do in order to kind of alleviate the obsessions. So sometimes they can also be referred to like ritualistic behaviors too. Like they just do certain things, and they have to do it a certain way for a certain number of times in order to be comfortable, to feel relieved from that. So an obsession is basically, it's persistent, it's unintentional, it's unwanted thoughts and urges. And often the individual that's experiencing them views them as distressing, that they're not pleasant. Some common obsessions, germs, contamination, doubts, order and symmetry is another one. Everything having to be in a certain place and symmetry. And then also can be involve aggressive or lustful urges. And then compulsions, like I said earlier, they're repetitive, they're ritualistic, they're, excuse me, I'm sorry, they're primarily carried out to minimize the distress about the obsessions, and to reduce the likelihood that the feared event will occur. And it's not performed out of pleasure. And the person usually knows that what they're experiencing is irrational. And again, that just kind of creates more distress for them. So approximately 2.3% of the population will experience this in their lifetime. So not a large population, but enough. And again, so some of the ritualistic things like frequent hand washing, locking the door, 1, 2, 3, 4, right? Turning it on, turning it off, lock, open, lock, open, lock, open. And then they're finally convinced on the last one, on the 7th one, whatever it is their number is. Let's see a couple of chats. Yeah, so so someone in the class is just kind of sharing that they kind of experience that, and yeah, and it can be distressing. It can be. So thank you for sharing that with me. Second. So when it comes to genetics, if you have a relative, a first-degree relative, so we're talking like sibling, things like that, you are 5 times more likely, it's 5 times more frequent, sorry, in relatives of people with OCD. Identical twins, there is a 57% concordance rate. Fraternal twins, there's a 22%. And then, of course, it's the genes that regulate the function of serotonin, dopamine, and glutamate. And there's also a brain area, which I think is on the next slide, that I'm going to want you to know about as well. But some conditioning theories, again, we're talking about conditioning again, learning theory, that it's learned responses, right? So the neutral stimulus plus the unconditioned stimulus leads to the anxiety or the distress, right? So whatever it is. And then once the association has been acquired, right? Encounters with the neutral stimulus now trigger the anxiety and the obsessive thoughts. So the neutral stimulus then becomes conditioned, doesn't it? So anxiety, the obsessive thoughts continue until a strategy is identified to relieve it. So whatever it is, that counting or opening and locking the door 7 times, whatever it is. And then the relief may be ritualistic behavior, which is what I've been talking about. And then the compulsive acts actually become negatively reinforcing, right? So, so we're talking operant conditioning as well. And so here's the OCD circuit as that I had alluded to. And let me hit the whatchamacallit. So the orbitofrontal cortex, what is located right here. And orbital, because it's right behind the orbits of your eyes. So it's in the area on your frontal lobe that's behind your eyes. This is thought to be overactivated, overstimulated in individuals that experience obsessive compulsive disorder. Excuse me. That it becomes hyperactive. And excuse me. So there is a question, I think this is like the only question about a brain area that I can think of on the exam that talks about the OCD circuit, right? And mainly, so the orbital frontal cortex is involved in obsessive compulsive disorder. The prefrontal cortex is involved with body dysmorphic disorder, which we had talked about with the eating disorders, and then the anterior cingulate cortex with hoarding disorder, which is another form of right, OCD, right? Afraid to get rid of things, getting rid of them makes them extremely anxious. All right. All right, so we're going to talk about PTSD. We have talked about this in a previous chapter. I'm going to hit on the criteria again. I did not have this slide when we did a previous lecture, but I kind of talked about the criteria for PTSD, but here you see it presented. So the diagnostic criteria, in order for someone to be diagnosed with post-traumatic stress, they have to meet criterion A, which that's how it's listed in the DSM-5. And criterion A is basically that they have been exposed to, witnessed, or actually experienced the details of a traumatic event, right? So they, actual or threatened death, serious injury, sexual violence, those kinds of things, like extreme traumatic event, they've had to have experienced it, right? And PTSD was first recognized in soldiers who were engaged in combat. I think, remember in the previous chapter, when I talked about PTSD, back in World War I, it was known as shell shock, right? And, in World War II, people were experiencing PTSD. Oh, it wasn't called that then. It wasn't called shell shock either. I can't remember what they called it in World War II. But they recognized it then. They just didn't know what it was. And of course, Vietnam and now there's lots of effective treatments for it. We'll talk about treatments for PTSD in chapter 16. But the symptoms for post-traumatic stress have to occur for at least 1 month. And so what are these symptoms? Intrusive and distressing memories of the events, dreams of the events, flashbacks. And so with the flashbacks, here's what's key with that. When the person is actually experiencing the flashback, they are actually reliving the event in that moment, and they're behaving as if it is happening to them again. It's like they are there, they're immersed in it. They will avoid anything connected to the event. For instance, there is a case where, what was it? The McDonald's, I think it was the McDonald's shooting that happened here years ago. And a person that was involved with that would totally avoid the area, would drive miles out of their way just to not see that McDonald's. So that would be an example of avoidance of the stimuli connected. They also experience persistent negative emotional states. So they're unhappy, they're distressed, they're irritable, they feel detached from people. They are an individual that is experiencing post-traumatic stress are prone to having outbursts. And they also have an exaggerated startle response. And what's really interesting, I was working with an individual with post-traumatic stress, and he would come in, this was, oh wow, 4 or 5 years ago, but he would come in and he would complain about muscle aches and his legs hurting all the time. And so we were doing some work with him. And anyway, one day he comes into session with me and he said, Richard, I figured it out. I know what's happening now with my leg pain. And so, you know, we talked about it. And what he told me is he would get on the trolley and he always had to have, you know, he had to be near an exit, escape route. And he always positioned himself in the best position he thought, where he could observe. Where's the danger? Where's the threat going to come from? And he said, when I realized I was doing that, he said, I realized my legs were tensed up, like my legs were ready to go. And he had never really noticed that before until we started doing some work with him. And he was becoming more aware of his somatic symptoms. So it was pretty good insight on his part. The prevalence of PTS is about 7% of the population in their lifetime. So remember earlier, or in the previous chapter, I'm going to repeat it here. Just because an individual does experience a traumatic event.
I think you froze, Professor.
All right, can anyone hear me? Give me a verbal. Can anyone hear me? This is probably being recorded, and this will be really funny on YouTube. Hold on one second. Okay. I can't tell if it's recording or not. Sorry, just having some technical difficulties. I believe that it's recording.
It's okay. You're doing great.
See, I love you guys. Okay, it's in recording. You know, where he had gained some insight regarding his somatic symptoms and leg pain, and you know, when he was out in public or on the trolley, his legs were always clenched. He was like ready to go. And this would be an example of some symptoms that he was experiencing as a result of that. And I believe I was leaving off when we started having the technical difficulties about the prevalence rate of about 7% of the US population in their lifetime will experience this. And the other thing I was saying, hopefully I'm not repeating myself again, but that just because an individual has experienced a traumatic event does not necessarily mean they will go on to meet full criteria for post-traumatic stress. It is a risk factor for it, but it does not always occur. All right. I'm getting another internet unstable warning. So if I freeze, just hang in with me and I'll be back. But some risk factors we've talked about: trauma experiences. Another risk factor, which is really important, and we talked about this also in the stress and lifestyle chapter 2, about the importance of social support. So a risk factor for PTSD is if I don't have social support and I'm have experienced a trauma and have no outlets, right? No support, that can increase the risk. Any other life stressors that happen after the fact can also lower socioeconomic status, lower intelligence, on the bell curve, any history of childhood adverse events, family history of mental health concerns as well, because remember that is there's some heritability there, and then also some personality characteristics. If you remember from the personality chapter, neuroticism being one of them. They may experience a higher risk factor for PTSD. And then also one or two of the short versions of a gene that regulates serotonin. That is also involved with depression, as you will see coming up. There's also, again, going back to classical conditioning and cognitive. Okay, I cannot tell if it's recording because it's not giving me my indicators like it normally does. Can anyone hear me?